I am Adam Pertman. I'm not the voice that you hear every week, which is that of Daniel Stein. Daniel is the head of Stewards of Change and of NIC. I am a senior consultant with Stewards of Change. I've been with the organization, almost 5 years. Time flies. I'm a senior consultant. I work on virtually all the various facets of what we do, working closely with Daniel and the team, some of whom are on the call today. Primarily, I work in strategy, communications. I am the communications and coordination director of NIC, which is what brings me here to this group. I'm filling in for Daniel because he is on an airplane right now. He may even be listening in, but probably not talking. Hi, Daniel, if you're around. And Daniel is on that plane coming home to New York from California, where he was giving a keynote at a conference yesterday. So I'm filling his shoes today. And truly, I am so happy that today is the day that I'm filling in with this group, because the subject matter that we're going to be discussing is child welfare. And that is something that is very, very near and dear to my heart. Before joining Stewards, I headed a national not-for-profit organization in that space that dealt with basically a think tank that conducted research, did advocacy, education, and so forth. And I still had a small not-for-profit in the child welfare space. So it's something I care a lot about, and I'm truly happy to be here and looking forward to the presentation. It's going to be about something some of you hopefully have heard of, but probably not all of you, called the Family First Prevention Services Act, one of those important pieces of legislation that more people should have heard of. It's a real disruptor. You'll hear more about it in a few minutes. I'm not going to describe it, but it is genuinely, potentially, a real game changer in child welfare, and certainly one of the most important pieces of legislation in the field for a decade, maybe for a generation. I mean, it's a genuinely big deal. So I'm looking forward to the presentation. And in particular, I think because this group deals with interoperability and data sharing, we don't often, I think many of us do not often think about those processes relating to child welfare. But in fact, they're critical, and they don't, by the way, child welfare does not do enough information sharing and back and forth. But if you think about it, it's critically important, and these are some of the most vulnerable people in our country, especially the children, but also their families. And they deal with all the stuff that we talk about, the cross-sector stuff. These kids are in school, they wind up people wind up in hospitals, they deal with law enforcement and the courts, and on and on and on, across all the domains in which all of us work, but though we don't always think about that intersection with those domains. And it goes even further. It's issues like race equity, economic mobility, all the social determinants of health and well-being impact these children and these families. And so I think this is really a wonderful and important topic for us to be discussing today. So a little bit of housekeeping. Whoops. Bear with me. This is my first outing here. There we go. There's the housekeeping. So please do keep your mics muted. We will mute them for you if we hear you having a conversation with your next door neighbor, or if there's sirens going off in the background. But please do keep yourself muted unless you're talking, which we want you very much to do. We do not want this to be sort of a long presentation with a couple questions at the end. Those of you who have been on these calls know that they're very interactive. I mean, this is a group that wants to chime in, that wants to participate. So we invite you to do it in lots of ways, and you see them here on the screen. Write in the chat panel if you want, raise your hand if you want to be called on to speak. But also, if there's a break in the conversation, absolutely feel free to come in, make your comment, ask your question. We want this to be interactive. And we would also like to see your face. Daniel jokes that you'll win a prize or something if you get extra points or something if we see you and not just hear you. It is a different experience if you turn on your video, and we do ask you to do that. But however you do it, we want you to be involved in the conversation, and which will be, and all of this will be recorded. If for those of you who have not yet signed up to the hub or to this group, there's the URL. Please do it. We think you'll enjoy today's call, but the work that we're doing is not just today, and we would love for you to be involved in it. So the agenda is, there I am. I'm Adam Pertman, so welcome again. We will start with participant introductions. We'll do that right after this slide. I will ask everybody who is new to the call, to this weekly call, please type your name into the chat box. Then I will call on you individually to introduce yourself very briefly, just your name, affiliation, if you want a sentence about what you're doing here today. Then we'll go from those new participants, and if you haven't been on the call in a long time and want to be reintroduced, that's fine too. But people who've been on regularly, please do not. This is meant for new folks. Then I'll give you a quick overview, mainly for the new folks, of NIC, and then we will move into the discussion and presentation with Meg and Christina from APHSA, which I think we're all looking forward to. After they are done, we'll have just a little bit of time at the end. We will check in with Dave Walsh, our colleague who is leading our Project Unify, which is a proof of concept that we are working on with this group, this Let's Get Technical group. If you haven't signed up and you want to participate in that, we welcome more participation. We have good participation, but more is better in this case. We want people to get involved. And then I'll end with a very brief look at what's coming up for this group in the weeks to come. I will say that, but not next week. We will take off for the holiday. So before we go into what is NIC, if new folks could please type in, I'll try to find the chat box. If you could type in your names, just your names into the chat. If you are new, and the type is small, so I'm going to be looking at the chat box. I think I see, whoops, it's moving. Danya, am I pronouncing your name correctly, Danya? Please speak up for us. Introduce yourself. Ooh, they're coming fast and furious here. Danya Barroso Conde and Patrick Tamashiro, are you on? Unmute yourselves and say hello. Hello.
Sorry, we have to mute our phone and from Zoom. But yes, we are here.
And can you just quickly introduce yourself? What you're doing with Connect Well San Diego?
Yes, and thank you. You did get my name correct. I don't think you heard us the first time, but good morning, and my name is Danya Barroso Conde, and I'm with Connect Well in County of San Diego, and I'm here with my colleague Patrick.
Good morning.
And we both just work on this project that's for data sharing with the County of San Diego, and we also work and collaborate with our other departments here, like Child Welfare Services.
That's great. Yeah, you guys do a heck of a job in San Diego.
So we're here today to support our colleague Margot Fudge over at Child Welfare Services to really take away some key points from this conversation so that we can, use the child welfare data in the most opportune way.
Great. Okay, Mary Ellen Wiggins. Unmute.
Hi, and I put myself back on video too. Sorry, y'all, I'm having lunch and wanted to spare you that vision for the webinar. I'm Mary Ellen Wiggins. I work with the Forum for Youth Investment and the Director of Policy and Research. And I'm here because one of the things that we do is run state and local level networks for children's cabinets, which is a very catch-all term for policy coordinating bodies that can exist at the state level, the local level, out of a governor's office or a mayor's office or a local agency. but often in government, they are one of the few places where people come together from across departments to really think about how collectively across the many missions that people have, there can be a whole person, whole child, whole community approach to doing the right thing for youth and for kids. And so obviously a lot of people in our network are thinking about family first. So I just thought this would be an interesting webinar to join to make sure I have the right level of awareness myself.
Wonderful. Thank you for being here. Now I'm going to work to pronounce this name. Anise, do you say it Anise? Correa Gabel? And I probably got all
right.
that.
Hi, Anise Correa Gable. Nice to meet you. Yep, I'm the Deputy Director of Data and Analytics at the Rhode Island Executive Office of Health and Human Services. So I just started here. Yep.
Welcome.
Thank
Kim
you.
Magoon.
Hi, yeah, my name is Kim. I work on Republic Consulting Group, and we do child welfare and substance use evaluations all across the country. So Family First is very pertinent to our work. So I'm just here to learn more.
Great. Margot Fudge, more San Diego. Margot? Margot, unmute if you're still with us. Why don't, Margot, while you're unmuting, we're going to go to Jamie Pistel, or Pistol? Jamie? Well, I see that, Jamie or Margot?
Can you hear? Yeah, can you hear me? This is
yes,
Margot.
Yes.
Okay. Sorry about that. So I am the Deputy Director over Policy and Program Support, including data for the County of San Diego Child Welfare Services, and I'm a little familiar with Family First, but interested in learning more about the data sharing piece because our child welfare data is so confidential. So I'm looking forward to learning more.
Great. And Jamie, are you unmuted yet? Okay. Jamie, while you are looking for the unmute button, Jerry Barr. Hello, Jerry. Okay.
You hear me?
Angela, who we got?
This is Jerry Barr with Maximus, and I have I'm a senior project manager for our Miami project and in Florida, working in Title 4E, TANF, Medicaid, adoption assistance, and SSI.
Great, great. Angela Rail, we have a lot of new folks here today. Angela, are you there?
Hi, can you hear me?
Yes.
Hi, I am here with, we work for the Tennessee Department of Human Services, Jamie Pistol and I. She couldn't find her unmute button. So we're new to the group, and we got this invitation from our supervisor, and we're just interested in what you guys are doing.
Terrific. I think it's great that so many child welfare folks are on this call. Again, it is an area that is too often overlooked when we think about about information sharing and interoperability, and yet it is such a massive population that, like all others, will benefit when interoperability and information sharing are real and take hold. Jackie Hamed and Sarah Foster. Are you there? If you're new, take a look for your mute button, because I'm going to call on you.
Oh, yes. Hello?
Hi there.
Hi, can you hear us?
I can.
Oh, perfect. Yeah. Apologies for that. We unmuted on the phone, but it looks like we have to do it on the computer as well. So this is Jackie Hamed and Sarah Foster. We are with the County of San Diego Health and Human Services Agency Office of Business Intelligence, and we are here to support Child Welfare Services team and just to learn a little bit more about data sharing and how we can assist with that. Very excited to learn more.
Great. Uma, you're with us. Will you come say hello? Uma? I'll wait for Uma. How about Rena? Another familiar name. Rena, you want to say hi to the group? Everybody start looking for your unmute button. I'll tell you what, if you're new and your name is on this list and you know how to find the mute button, excuse me, would you say hello, please?
Sure.
And introduce yourself.
This is Brett Brown. I work in the Office of Planning, Research, and Evaluation at the U.S. Department of Health and Human Services, and very interested in seeing and learning more about what states are doing in data sharing, because I think it's an essential component of a kind of a prevention-oriented program like Families First.
Excuse me, I'm plugging in my computer before it goes dead. Okay. Sorry about that. Thank you. Thank you for joining us. Anybody else new who can find their unmute button?
Hi, this is Luis Fernandez.
Hi.
And I supervise the County of San Diego's Child Welfare Data Unit.
Great. Great. Other newbies?
Hi, this is Tom, and I'm with Strategic Systems, and we're getting a lot of requests, and I'm excited about all the interoperability benefits.
Great. Great. Who else have we not called on who is new to us?
Hi, my name is
Richard Thomason. I'm Policy Director for Blue Shield of California Foundation, interested in state strategies around data sharing. Thanks.
Terrific. Thanks for being with us. And I heard another voice.
Hi, my name is Gail Koenig, and I'm also with the County of San Diego with Behavioral Health Services. And of course, we interface often in serving kids that are also involved with child welfare.
Who else we got?
Adam, can you hear me?
I can now.
Good. For some reason that I called in anyway. Hi, Rena Burns, IBM, and you already, I think, I've worked with Health and Human Services for easily 20 years, possibly longer. Quite interested and happy with this legislation and looking forward to learning more.
Great. And Rena's an old friend of the Stewards of Change. Who else we have? I think we have a few more.
This is Dean Duncan from UNC at Chapel Hill School of Social Work. We've been using data to track outcomes from human service programs in North Carolina for over 20 years.
Great. We have quite a diversity of people coming at this from different directions. I think that's terrific. I think we have a few more. Who else has not spoken up if they're new or reintroducing?
Walter Sapersky here with IBM. I focus on health and human services, and I'm responsible for our solution called Connect 360.
Great.
And hi, this is Kat Patterson, Senior Analyst at the Association of State and Territorial Health Officials. I'm also glad to be here and just learning and listening.
We are all doing that. Anybody else?
Hi, this is Dan Jensen from Olmsted County Health, Housing, and Human Services. I work in the strategic informatics area. We've done a lot of great work on the public health side, and we're trying to expand that and do a little better work on the human services side of things.
Sounds good to me. Others? Going once? I know there are a couple people who signed in who have not spoken up, but that's okay. I want to just give it one more second. Anybody else who has put their name on the list as being new who has not yet introduced themselves? Okay, then let's get going. And if at any point any of the people who are new, who haven't introduced themselves, if you have a question or comment, you can introduce yourself at that point. So I'm going to make this real quick, introducing Nick, simply because we have so many new people that we took more time than I think we anticipated, that I'm sure we anticipated. So the National Interoperability Collaborative, I'll just put this straight up, is about 2 years old. It started with a generous grant from the Kresge Foundation, which has been renewed. Thank you, Kresge Foundation. And it is a community of networks, what we call community of networks. The idea is that lots of people are doing collaboration and interoperability and information sharing, but a significant portion of the time, what we're doing is growing individual silos. They're getting bigger and bigger. And so NIC is designed to be a place where all those silos can come to learn from each other, to teach each other, to share resources, to work on projects. And this particular exercise that we do every Friday is just one example of the kinds of work that we do. And we do it across what we call domains. Some people call them sectors. But they're systems that need to talk to each other, that need to interoperate and learn from each other if we're going to really improve health and well-being in our country and on this planet. And so far, so good. We've gotten really good engagement. The only other thing I'll say very quickly is that we fully recognize when you look at those 6 domains that that's not all there is. But they are writ large, and we certainly work in other areas besides the one specifically mentioned here. But we wanted to at least describe how encompassing this work is and should be. Okay. And there's the URL for the hub. If you have not taken a look, if you have not yet signed up to be a member of NIC or to join this group, we hope that you will, individually and with your organizations. We have, I think, about 100 organizations now, and many more members than that. And with that, I think I can turn over the microphone to Meg and Christina, whose bios are on the screen right now. And Meg and Christina, I will be advancing the slides, so you just let me know when it's time to do that. Okay? And with that, please take it away.
Thanks, Adam. First, we're very excited to be here today, and thank you for the opportunity to have this conversation. This is not a group that I get to speak to, and it's a very diverse group often. I am in the weeds of policy, and that's pretty much what I do every day. So I'm hoping that this conversation could be a good level set for everybody on the phone and how the Family First and the changing child welfare landscape is affecting your work and could affect your work going forward. And Adam mentioned this at the top of the call, but we really want this to be interactive. So feel free to ask me questions, give me your thoughts. This is an opportunity for me to learn as well from what's going on in your respective fields. Because like I said before, this is not a group I get to speak to often. So we're really excited, and I'm Megan Dykert. I should probably start with that. Child welfare lead for APHSA, and on the call today is my colleague Christina. And Christina, I will turn it over to you to do a brief introduction of yourself and APHSA.
All right, thanks, Meg, and good afternoon, everyone. My name is Christina Becker. I'm the Knowledge Mobilization Manager with APHSA, and I've been with the association for about 3.5 years now. And I also work as a policy liaison to one of our membership groups that maybe some of you on the phone are going to be familiar with. It's called ISM. It's the Human Services CIO peer group. So I'll talk a little bit more about APHSA, and then if any of you all are not familiar with us at all, please do feel free to ask questions. But basically, APHSA stands for the American Public Human Services Association, and we are a bipartisan nonprofit membership group, and we represent state and local health and human services agencies throughout the country, largely through their top level leadership. So governor appointed human services secretaries or commissioners are our main membership group, but we also house several disciplines in health and human services whose members are the administrators that operate agency divisions or departments in states and counties. So that includes, like I said, the ISM group, which represents human services CIOs. But we also have another, like very many other peer groups. We have, for example, a membership of SNAP directors, TANF administrators, child welfare administrators. And I just see somebody was saying that we've lost sound. Can you guys all still hear me?
Yes, we hear you.
Yeah, it's just fine. Yep.
Thank you. Sorry, Sarah Foster, you're out of luck, I guess. I don't know. But yeah, so just like I said, we've got a very broad membership group all across the spectrum of human services. And do feel free to check out our website. We've got lots of information on there, and you're able to plug into our work. And just to clarify, you know, what our members and stakeholders like you work on together with us is influencing policy, you know, on the Hill, leveraging and sharing modern policies and practices from the field, and connecting our members through conferences and webinars. So Meg and I do a lot of these kinds of presentations with commissioners and secretaries from across the country. And like Meg said, this is, you know, like the really in detailed interoperability pieces of Family First haven't really been figured out yet because we're still just trying to implement. But I think we would love to hear from you all what some things are that we should keep an eye out for, or if you've done anything similar to this, we'd love to learn more. So Meg, I'll hand it over to you unless anybody has any questions for us at the top. Okay, Meg, it's all you.
Thanks, Christina. And to piggyback off what Christina said, I work mainly with our child welfare directors group. And so we are very much in the weeds of implementation. And so this is definitely a great opportunity for us to get your different perspectives, because I work mostly with the public sector. So with that, let's crack into it. If you can advance the slide.
Yep.
All right, so I wanted to start with a kind of where we've come in child welfare, because we've come really far in what is historically a relatively short amount of time. Now, child welfare kind of in the beginning was very much kind of in that rugged individualism that we saw in early America, and one's circumstances were directly related to her perceived lack of morality or work ethic. And so the government and the public was very hesitant to fund social programs. So we saw a very slow uptick in the emergence of child welfare programs. In 1935, we had the Social Security Act, which established federal funding for the first time in child welfare. Other states had been funding child welfare before this, but very small, and most of it was through faith-based organizations. So what you would, the classic orphanage kind of Annie style, that's where we were kind of at during that time. And much through the Great Depression did attitudes change. In 1963, we saw the Aid to Families with Dependent Children that amended the Social Security Act, which included a federal match for state foster care expenditures. This was a moment in the modern child welfare financing stream and set up us for where we are today. And then of course we have CAPTA, which was the first major legislation addressing child abuse. And I'm gonna try turning off my video in case that's the problem with the audio. So unfortunately you guys will not be able to see my beautiful face anymore. All right, video's off, hopefully that's gonna help the audio issues. But CAPTA, we saw the first major federal legislation addressing child abuse and neglect. And this sets up for the first time requirements for states on reporting procedures and investigations. States were doing this before. This kind of sets up a federal baseline and where you have to be. Then the Indian Child Welfare Act is a response to the extremely high removal rate of American Indian children from tribes and cultures. Some states, it was up to 75% of removals for tribal children, and that is so far beyond the normal rate for non-people of color. And so that was an attempt to address a disparity that existed in our child welfare system. And then I would argue the next big legislation was the Family First Act, and we see that passed in 2018. Now, these are not all of the acts that the government has done to address child welfare. These are the biggest hits, and these are the ones that brought us to Family First and how it is now. And you guys will hear me, the bill is commonly referred to as FFPSA or just Family First. So for the majority of the presentation, I'll probably refer to it just as Family First. So these are our key federal milestones that kind of brought us to where we are today. And so this is an example of an average of the child trends. Every 2 years does a survey of all of state government spending on child welfare and how that formula is kind of made up. So this graphic represents an average of 26 states that responded to the child welfare financing survey done by Child Trends in 2016. So I know all of you on the phone know data moves very slowly behind the time. So this is 2016 numbers, but there wasn't much of a policy shift or funding stream shift in 2017 or 2018 that would have grossly affected this. So these numbers should be relatively the same for the last 2 years. But you can see a huge chunk of child welfare funding, over 55% on average, comes from state and local dollars. That is, it does vary by state. Some states you'll see they use their TANF dollars much more. And it just has to do with how the state does their own kind of formula, whether it's, county driven, but majority of our spending is state and local. And then you see the Title 4E, which is the federal Social Security, where child welfare funding comes federally, makes up about 25%. And then we have a mix kind of going down the line of TANF, Social Security Block Grant, Medicaid, Title 4B, which is more administrative payments rather than where Title 4E is foster care maintenance payments, which is the direct care for children who are placed in out-of-home placements. And then other federal would be different grant programs, those weird one-off funding streams that you see sometimes come in down in appropriations. So now I want to kind of level set in where the idea of Family First came from. Family First was a push from the field more so than kind of top down. This was people who work directly in child welfare saying that we need a change and the way that we're operating is not working for our children in the long run, and it's not working for our society in the long run. And that came off of the idea of social determinants of health. And I know many of you on the call are very familiar with this, but they are the conditions in which people are born, grow, and work and age. They include factors like social economic status, education, neighborhood, physical environment, employment, social support networks, and access to healthcare. Those are kind of the main hits when we are thinking about social determinants of health that we want to focus on. Now, how this links to child welfare is a 2019 CDC study, it came out just a month ago, found that childhood trauma causes serious health repercussions throughout life and is considered a public health issue that calls for concerted and immediate prevention efforts. Now, I have a little graphic here just to kind of show what we're talking about, the different categories we're talking about in social determinants of health. And so just to highlight a few, it's access to food, literacy, that's going to affect, your life throughout in many different ways, stable housing, employment, debt, if you can't ever really get out of a cycle of poverty, you're never going to really grow. And that we see span generations. So social determinants of health is also about breaking generational issues that have existed and that have held down a family or a group of people from really realizing their true potential and thriving. So we're seeing this push in child welfare now very much coming from the understanding that we need to create conditions to which families and children can thrive. And that's the basis of, you know, whether they're going to be successful and if we need to intervene in the future for them. If you can advance the slide, please. All right. Now, I just want to show, when we're talking, this is known as the prevention triangle, or pyramid, not a triangle. I always want to call it a triangle. But it is what our idea of prevention ideally would come from the primary prevention. And the bottom also says universal. That's commonly referred to in child welfare, we use primary prevention. And that would be, you know, there wouldn't necessarily be a need for a child welfare system because we are hitting all the problems at the head. And right now, the child welfare system is balancing between tertiary prevention, which is only responding to times of crisis. So when there's a child already being neglected or maltreated, then we step in. Many would argue that family first, and I agree with them, is not primary prevention because you're identifying children for some reason who have the possibility to slip into foster care and for their families to need to have them placed. And so it's very much secondary prevention in targeting families who need additional supports. So this Family First is not primary prevention, but it's an attempt to move the field toward primary prevention. You know, you can't move from a reactory system then into one that is primary prevention. There has to be kind of a gradual move towards that, and Family First is the first step in that direction. And my favorite quote from Jerry Milner, who is the Associate Commissioner for the Children's Bureau, is, and he was talking in regards of primary prevention, is you can't cure polio with more wheelchairs. So this is the idea of, you know, creating that vaccine, that primary prevention, and introducing that into child welfare. So just to show this on a national context, this is very much what APHSA does for elevating all of our good policy on the national level. But we're really focusing on adjusting fiscal policy to incentivize prevention and early detection or early intervention. You see that a lot now with Medicaid. There are more incentives for states to expand now coming out of Congress, their pools for services, data optimization at individual and community levels through population data sets. We are seeing the conversation of data explode right now in child welfare. Before, you know, that really wasn't a huge concern for theirs. So now data is becoming much more of an issue and a moment for child welfare because it is going to be the basis of pulling candidates for prevention services, but also tracking the success of prevention services, which is another big part of that legislation. Is we want to make sure if we're throwing money at a new program that it's working. So data is becoming much more important in child welfare. Not that it wasn't before, but we're really seeing an increased focus on it. Understanding and addressing the social determinants of health and how that affects well-being, applying a multi-generational and whole family approach. That is the basis of Family First, is the idea of breaking these cycles that allow families to fail. And those are cycles, you know, whether they're addiction or poverty, and also not just treating the child in care, but treating the family unit. And we've seen that as the basis of success in keeping families together, is treating the whole family unit and not just the child. Applying human-centered design principles. A big part of Family First is evidence-based programs and having culturally appropriate programs. So there's a huge shift in allowing those, in having those programs be truly impactful and looking at which ones are. Now, the rest, those are important, but not so much for this conversation, but that's a general look on how APHSA does this on a national level.
Hey, Meg, this is Christina. Just really quick before we jump ahead, since I do have to jump off at 1, I was just wondering if anybody on the group has any questions, any clarifying questions. I know there's lots of people from different domains on here. So, you know, are the things that Meg was sharing in terms of child welfare funding and primary prevention, are those all clear? Are those resonating with you?
And to piggyback off what Christina said, are you seeing the social determinants of work affect your work right now? Because it's been kicking around in Medicaid work, particularly for a while now. So if you're seeing this in your, you know, before we moved into Family First, how is this affecting your job right now?
All right, maybe everybody's eating lunch. I was just going to say, Greg Bloom, in response to your question, I have read Virginia Eubanks' book, Automating Inequality, and there are a lot of good parts in there about how states and counties are using data, whether equity was part of the design principles, and, you know, for these kinds of services. But I would love to hear what you think is really pertinent from that book, Greg.
Yeah, I think I'm thinking of, I mean, the basic thesis of the book is that when there are institutions that either, you know, directly or indirectly yield inequitable outcomes, and, you know, because of systemic discrimination, so on and so forth, especially with regards to race, but also gender and so on. When technology is designed to make those systems more efficient, to be able to integrate data from one place to another in order to, like, for example, better anticipate when a child might be at risk, that the result is by default to actually amplify those unequal outcomes. Unless the technical intervention is designed specifically to negate those unequal outcomes and to redress them. And I think a couple of examples were specifically in the field of child welfare, where, like, examples such as, like, a family had a neighbor that didn't like them, presumably for reasons that one might reasonably assume are racist, and that neighbor kept calling to report that family as you know, as a, you know, potentially, like, mistreating their child, because the child was running around in the yard, right, over and over again. And that nuisance call, which people using the call center know is like, okay, they're not going to call 911, they're not going to send the police to intervene here because it's just a child running around in the yard. But because these systems are now interoperable, these calls raise flags, and the family is now elevated in the perception of this system as a risk, which increases the likelihood that potentially they'll be deemed, like, you know, unfit as parents, and the family will be broken up. And there are other examples where, you know, the behavior of a daughter's boyfriend who maybe gets in trouble with the law suddenly becomes a flag in someone's record that threatens their ability to keep access to benefits and keep access to housing. And so these weren't the intentions, right? The intentions of these systems were to make it easier to anticipate when someone's at risk. But if it's just a technical intervention, then that ends up feeding all of these inputs into that process that might yield unjust outcomes. And so I wonder if you can speak to these challenges.
Yeah, thank you. Oh, go ahead, Christina.
I was going to say, Meg, I'd be interested actually to hear what you think about this, because I think, so Greg, you're thinking in terms of, you know, the use of predictive analytics, and you know, using data to inform decisions. And I think maybe some of that is not quite where we're at yet, Meg. I don't know whether we've seen any examples of that, just because with Family First, it's really just, quote unquote, just a change in how child welfare is funded, not necessarily like, so it's more about the program administration. But Meg, I don't know whether whether anything in the clearinghouse, whether any of those programs are using data in that way. I'm not sure.
Well, that is actually, so there's a section at the end of the presentation where we're going to talk about the opportunities that exist in Family First and because of Family First. And Christina, you're right in the fact that it is mainly a shift in funding streams, but Family First also allows states to set their own candidacy definition for what is a candidate for foster care, and how they pull that data has been a hot button issue. And so I want to put a pin in that. Greg, I'm very glad you brought that up, because that was exactly the conversation I want to have. And we will, there's a section later that I think will be better for this conversation, but definitely there is a lot of conversation in using predictive analytics to pull populations, but then also not even the predictive analytics side is, privacy concerns and pulling these data, and where the right to privacy for the parents and the families and, anybody else, the mom, grandparent, and kinship involved, where that line is drawn. So yes, that's a huge conversation that is happening, and one I would really like to have with this group, but we'll put a pin on that until towards the end. I just want to check if there's any other takeaways anybody wants to mention at this point on just social determinants of health and the changing landscape and the ideas of what and what we are focusing on as a federal government.
Yeah, this is Adam. I think we want to keep moving just because I know how much content is left and I want to get through the bulk of it. Just real quick, I want to point out that when you show the social determinant, it makes it paints such a clear picture of why we need interoperability and information sharing, because in order to identify those families who are vulnerable, we have to have information from more than one place. I mean, it simply isn't true that if you get something from the school, then you're going to know everything you need to know in order to make a determination. It's going to become increasingly important to share that information in what is one of the most private, some people would say secretive, institutions in the country. So I think that's going to be quite challenging and quite a process as it unfolds. Right now, it is just primarily a funding mechanism, or a shift in a funding mechanism. And the other challenge, I think, is very clearly what Greg pointed out, which is that we need to do this as the process proceeds in ways that are very conscious of bias and the potential of bias to muddy the waters. That's all. And so if we could, let's just keep going.
Yeah, I'll dive.
And by the way, anybody wants to jump in and comment on anything I said, as well as the presenters, please do. But let's give this a few more slides.
Yeah, so I just want to kind of shift real quick to show what we look at in child welfare through a primary prevention lens. So what it is focused on is really reducing economic disparity, which is the leading cause for child neglect and child maltreatment. You can see that in the cases of mothers who are forced to leave their children at home overnight to work a second job, and then that is considered neglect. You see that with a family who can't keep the lights on and keep food on the table, and so a child is placed. So really reducing the economic disparity that exists is the leading drive there. Increased knowledge about how children develop and what to expect at each age. A big portion of that is attachment with the parent and creating early bonds to the next point there in the child. So if a parent and child bond early, it's much less likely for that child to ever be placed, or for the child and the parent to ever be in contact with child welfare services. Increased stress management skills. So these are more focused for the parents, and increased knowledge about managing homes and families, changing social norms about parenting and positive parenting. Creating community capacity for support is crucial too. A sense of community and a sense of belonging are huge in creating a successful family unit. And ensuring those who work with children are at their very best. You can go ahead and we can move on to the next slide. All right, so this is the meat and the bones. This is what I spend all of my day on. I pretty much sleep with this legislation underneath my pillow at night. It's my best friend. So I want to give you guys a quick introduction, and please, I'll try to pause for questions, but if you have them, please let me know. I find sometimes I am so in with this that I'm speaking at a level that is not level setting for everybody. So please let me know. So Family First had been kicking around in Congress since early 2015. And it was a long, drawn out negotiation process, and it took a lot of different forms, but very surprisingly was signed into law as part of the bipartisan budget deal of 2018. The Children's Bureau didn't even know that it was going to be voted on and improved that day. So it was even a surprise to HHS. And the implementation period started with the fiscal year in October 1st of this year in 2019 and remains until October 1, 2021. Included in the bill was a provision for an optional 2-year delay. This is a huge funding shift and a shift away from a lot of practices that states have been using for a long time. So this was not going to be a quick fix that we could shift. States need time to plan and transition away. And this is also butting up against the sunsetting of the waiver that a lot of states were operating, and the waiver was issued to allow states to be innovative with their federal funding and child welfare. So Family First, we've mentioned it before, reforms the child welfare streams. Before, Title IV-E of the Social Security Act and Title IV-B could only be used for the direct result in expenses to house a child, to actually place a child in care. And that is tied to a federal statute of the aid to families with dependent children. It is that is linked to child welfare, where the federal government does not do a federal match if the child's family falls above a certain level. And that level has not moved since 1996. So before, when we saw that slide in child welfare spending, the reason that is the federal pot is kept pretty low is because of that aid to families with dependent children linking that exists in child welfare. So for the first time, states can pull down Title IV-E and IV-B dollars for substance abuse treatment for child or there are children in care who are experiencing addiction. So this can address that too. In-home parenting skills, and that doesn't necessarily mean that those skills have to take place in the home. It can take place outside, but needs to be focused on parenting and creating a good family unit. So this opens up a lot of programs that we could choose from. And another big and one of the most controversial pieces of Family First is the move away from congregate care. So it is incentivizing states to reduce placement of children in congregate care by implementing what's called a qualified residential treatment program with very specific requirements, which we'll get into in a bit, and limiting bed numbers. And this stems from the idea that a child does better in a family setting, and we want to move away from what is considered the classic group home. This has been a practice, and many states have already been moving away from this. And these are typically where children with past trauma, so maybe some PTSD or mental health needs, have been housed, difficult to place children, if you will. So a moving away of placing them just to kind of put them in a group home and actually making these qualified residential treatment programs treat and address the child's needs and why they need to be placed in a group setting. States may use Title IV dollars to provide up to 12 months of mental health services, substance abuse treatment, and in-home parenting skills. At the end of that 12 months too, they could re-up, so that doesn't just limit it to 12 months. And also another important note here is that shortly after the passage of Family First, ACF backpedaled a little bit on the source of funding that would exist, and Title IV is now considered what is the payer of last resort, which means if any other federal program can fund these prevention services, they should, mainly being Medicaid. So that is going to be a huge opportunity that we'll also talk about. Thank you, yes. So services or programs under Family First must be trauma informed. This was a big sticking point in getting Family First passed, is if they were gonna fund up more federal dollars, we wanted to make sure that the programs that we were using made sense and were responding to all types of trauma. So Family First intentionally raised the bar in evaluating programs for services. To evaluate prevention services, they established a separate clearinghouse, which is the Prevention Service Clearinghouse. That contract was awarded to Apt Associates out of Maryland. It's a very low funded program, only at about $1 million a year. So that has been an increasing point of opportunity. Programs are rated as either promising, supported, or well supported. And to date, only 12 programs have been rated by the Clearinghouse, and the Clearinghouse has been up and running for about a year now, I believe. And of those 12 programs, I believe 3 did not meet criteria at all. And only, I think 5 are well supported. And that becomes a huge issue because currently how the bill is written, at least 50% of state expenditures reimbursed by 4E must be services and activities that meet the well-supported practice. And this is in order to qualify for the federal match. That is an increasing concern because these programs have to be trauma informed and fit the population that they're serving. So if they don't have a program to choose from that would fit a population, and this is particularly a problem for smaller states, states like Hawaii that have a very diverse population, tribes, it's a huge issue. So we're running into that as an opportunity. Federal Title IV reimbursement for foster care and prevention programs will be beginning with the new fiscal year this year, after September 30th, 2019, 50% for programs and services, and 50% for associated administrative costs. And I mentioned before, the big data shift is this was included in Family First, is that states must collect data on services provided for children. Oh, if you could back up one more slide just for a second, thank you. Must collect data on children receiving Title IV prevention dollars, the child's placement status at the end of the 1-year period, and then whether the child entered foster care within 2 years of being deemed a candidate. That's going to be huge. That's data that it's going to mean ongoing data collection on a child who may not be receiving any prevention programs, but it is required that they kind of check in to see where that child ended up. So that's a whole data that was never experienced before and never required. So that's going to be a whole new issue that states are looking at. You can advance the slide. And I'm going through a little quickly just because I know we're limited on time. So I am running through this a little quicker than I normally would. But I do want to break down QRTPs a little bit because this is, like I said, one of the most controversial and one of the reasons states are taking a full 2-year delay. So after 2 weeks, there will be no Title IV maintenance payments for a child not in a residential program unless it's considered what a QRTP is. And that's a specialized setting for prenatal, postpartum, or parental supports, independent living facilities for older foster youth, specialized programs for high-risk populations, which include those at high risk for sex trafficking or addiction, and licensed residential family-based treatment facility. And I'll just run through the requirements because many group homes are, or congregate care as we think of, are not set up in this way at all. So it's moving it into much more of a clinical setting. It has to be a trauma-informed treatment model that address the needs of the children who have emotional and behavioral disorders, have a registered and licensed nursing staff and other clinical staff who are available 24/7, facilitate family participation and outreach, documents how family members are integrated in the treatment process. And another big issue is providing at least 6 months of post-discharge is hard for a lot of states where these services are not spread out through the entire state, but more focused maybe in one region. It's hard to provide that care in a child's own community.
One thing, let me jump in for a second just to illustrate the complexity of all of this. Think about the reality of pulling kids out of group homes. I think we'll all agree they'll do better in families, but it means you need more families. I mean, if a group home has 8, 10, 12 people, you might need 8, 10, 12 more families. And we don't have enough families as it is, whether it's reunification or moving to a new one. So there are elements of this that are even more complex than it may seem on its face. It's a good time to break, I think. Does anyone have any questions or comments, I hope?
I'll ask a little bit more of a pointed one. This is a major shift for the child welfare field, and I know many of you work in different fields. Have any of you experienced such a major federal shift in your field, and how did that process go? How hard of it was it, or how great was it? You guys just really like my voice, don't you?
What this really is disruption in a real way. Are there, writ large, those of you who have done work in interoperability and information sharing, what are the big concerns? As they move to really a different model, is it privacy? Is it standards? What elements are the ones that you have encountered that you think will be relevant for the child welfare field as it moves forward? Someone jump in.
Bueller.
Okay, so everyone is too fascinated to speak up. So Meg, let's keep going.
Yeah,
this is Dan Jensen, and if I can jump in for a second.
Please.
Yeah, please.
We did a lot of informatics work on the medical side of things within public health and exchanging with clinical partners. And that informatics structure is around the individual. If you think about HIPAA and a lot of the data requirements, the individual is the key. The key to this work, as I'm seeing it unfold, is really at the family level. And there's a lot of barriers around interoperability design, around system design, around laws that are going to really create struggles in having a family view and having interoperability and data exchange. Because if you think about social determinants of health, the father or the mother's income is tied to that individual, but it impacts the entire family. So there's a lot of pieces that impact the family, and we need family views, but we're going to struggle because a lot of this great work that's been happening in the past is really focused on at the individual level.
Yeah, one other aspect. Please go on.
Adam, this is Tom Soviets, General Dynamics. I actually chair a nonprofit that's heavily involved in this kind of thing, up to and including identifying, as you mentioned, where those other parents are going to come from, things like that. One of the things, and I'd be happy to hear what the speakers think. One of the bigger challenges, aside from the data sharing parts of this is the, I'd say the added expense of trying to work with the legacy systems. So, you know, as we've transitioned from SACWIS to CCWIS and whatever future evolutions of that become, a lot of states and local governments are working with very antiquated systems right now still.
Yeah.
And the costs of getting to the kinds of data sharing that we're talking about, you know, putting families together in a cognitive way, things like that. Do we see this change in the funding stream being able to address any of that for states?
That is, yes, that is a really good question. And that's another side of an issue with not only Family First, but the child welfare field in general. We have states, I say states, I only actually know one, but there are states that operate still on a paper-based system whose entire Medicaid claiming is based on, you know, a paper-based system that ties up state and local funds for longer than it should. We have a lot of opportunities in some states on platforms that have already been created, not really fitting the needs of the field. So that is a conversation. I think there's a lot of states that did it right and have good operating systems. I can think of Ohio as an immediate example. And then there's just some states that are lagging behind, and that's going to affect how effective they are in not only pulling populations for prevention services, but tracking those prevention services. So yes, it is a major concern and one that's being looked at. And I think, you know, the federal government invested initially a lot of money in getting states to a more modern platform. And I don't know if there's any additional federal appropriations for that. So I think it's going to have to be driven on the state level. But that is just my my take on it. And looking and hearing conversations from the field, that is a significant worry of theirs.
Okay, why don't we keep going? We've got, I think, probably 10, 15 minutes left for the presentation. So jump right in.
Yeah, so this is a graphic that APHC created just to show what a successful family interaction under Family First would look like. So we're using a parental substance abuse as an example, but that's the point of initial contact. You say mom comes into the emergency room or is somehow identified as having a substance abuse problem while pregnant. So the agency would come in contact. The Family First allows for the mother and child to be housed together while treatment is sought. The first step there is we're focusing on 1, getting mom clean, and 2, creating attachment in a safe setting, which is exactly what those treatment services allow for. And then we would move into mental health services because Family First also identifies the relationship between substance abuse and mental health. And so we're trying to target the root causes of substance abuse disorders and untreated mental health issues and trying to target them so that we don't have failures in the future, then they would have to come into contact with the family again. Care coordination with Medicaid. Access to quality healthcare is huge for determining the success of any individual, but for family units and for young families in general. And also including the parents in that coordination with Medicaid and making them feel empowered in their healthcare decisions. Home visitation program, nurse or social worker would come in to help mom and child bond, but also work on positive parenting skills and seeing how the parent interacts in the home is huge. And then the end goal would be successful family functioning. So after prevention services, there's a generational stability that's created that would hopefully lift up future generations to no longer have to fall into a category that would be considered at risk. So that's kind of a look of what it could look like as an example. So data integration opportunities. These are going to be identifying population for prevention services, predictive analytics. That's you know, a little bit what Greg touched on before. And I use the example, the Allegheny Family Screening Tool, an assessment tool that is a statistical analysis of 4 years of prior calls using over 100 criteria in 8 databases for jails, psychiatric, public welfare, and drug and alcohol centers. This is kind of getting into those muddy waters of privacy concerns, but also, you know, Greg made a lot of excellent points that there could be families who are identified for, you know, improper reasons. You know, the neighbor just doesn't like them, triggers a phone call, but then that triggers them being tagged in a system. You know, how do you untag them, and what is the process for that? That's not really defined right now. And we do see states who are using, who plan to use predictive analytics in pulling their population for prevention services. I know Alaska is planning on it. Allegheny obviously has already been using it and would be using it to pull populations as well. Access to site capacity. The ability to share varies greatly across organizations. We also touched on that a little bit before. The system integration is a real issue in not only what we can share, but what they're willing to share. A lot of these systems do not talk to each other, and a lot of these programs do not talk to each other, whether it's Medicaid and early childhood or it's child welfare and early childhood. These are not communicating and pretty much on a basic level right now. So how do we do that? And then also real-time data exchanges. That is going to primarily affect on your platform that you're using, and whether that is conducive to the changing needs in the data. And then the last one is kind of more to the points of both of those, and a privacy issue. And this is a very extreme example, but I recently went to a conference of health attorneys, and this was their primary example as a parent being treated for HIV does not have to disclose to a social worker, but the social worker is made aware, you know, I use social worker loosely here, whoever's pulling data to be considered for prevention services. That's an unintended consequence. Their HIV status has nothing to do with whether their child would be a candidate for prevention services, yet that information is also disseminated. You know, maybe they were looking for history of addiction or any ranging issues. That's a huge concern that's the attorneys are thinking about, and a data concern as well.
Excuse me, Meg, just a real quick point to make, which is that this is predictive, non-analytics. It seems to me, and I think lots of people in the field see this unfolding as well, that the exchange, in the information exchange that's going to take place as this unfolds is really going to be pretty lopsided at first. Child welfare needs a lot of information from other realms, other domains, but because of the nature of the children and families they're working with, not a whole lot of, and there are trust issues here as well as privacy ones, but it's probably going to be a primarily one-sided flow at the beginning, and I think people are going to need to, and organizations are going to have to wrap their heads around that.
Oh yes, definitely. It's relationships that have never existed that are being brokered right now, or hopefully being brokered right now, that child welfare is never considered and is going to have to moving forward. So as Christina mentioned in the beginning of the call, this is still very much unfolding at kind of as we speak. We're in the very beginning of implementation. There were only about 4 states who were going to try to actively implement in October 1st. The leading drive of all of them is Kentucky, who has been doing some amazing work on Family First and has really been leading the charge in addressing the opportunities that are still outstanding. So this is a projection on what we could likely see in the future. when considering Family First. So an obvious would be an increase in federal spending in child welfare and prevention services. Now that's mainly, we're predicting to become from Medicaid. Almost all the programs rated under the clearinghouse right now are Medicaid funded programs. So that's going to be pulling from that budget and not necessarily Title IV-E, but still would be increase in federal funding. Now we'll definitely see more $40 being coming down because that is a funding stream, and we'll see that for administrative costs. But primarily we're going to see prevention services being funded through Medicaid. And it's going to be a gradual decrease in the number of children entering care, especially in cases of neglect. So if we're focusing on fixing the conditions that cause a family to fall into poverty, then naturally we should see less kids coming into neglect as we implement those programs and as we support families. Ideally, we would hope that that would reduce maltreatment, but maltreatment necessarily isn't always tied to neglect. So that's something that unfortunately is still going to be an issue. But if we can dramatically reduce the amount of kids in there for neglect, easily preventable, then we can really focus on turning towards preventing maltreatment, which is a whole separate set. Reduction in juvenile justice population, that's just would come naturally with families being lifted out of poverty. Higher quality foster care placements and the decreased average number of placements per foster youth. Right now, it's much higher for kids of color, but foster care placements range from about 5 to 7, which is a normal for a child. I've heard of 43 placements. And that's not creating a sense of permanency and is traumatic to a child to be uprooted that often. So we would see higher quality foster placements because there would be less children that needed to be placed, ideally, in a perfect Family First world. And better support and access to kinship care programs. That's a direct result of the substance abuse crisis. We see a lot more kids living with grandparents, aunts, uncles, other form of kinship care that right now there's no form of support for. So, you know, if grandma steps up and says, well, I don't want my grandkid in foster care, they're like, oh, that's well and good, but there's no support in place right now. Very minimal supports in place. So expanding that, and then that'll also lift up that kinship support too, because that's a burden placed on a lot of families to take in a child. So touched on a little bit before, the outstanding concern, Family First is not perfect. There's a lot of opportunities. It's not true primary prevention, but moving toward primary prevention. And the relationship with Medicaid is going to be the biggest sticking point. Right now, there's a lot of contention in the way that the funding streams was set up. Medicaid necessarily was not consulted. It was a bill passed coming out of the Social Security Act and then kind of switched on their heels to say, well, it's going to be funded through Medicaid. And Medicaid has already been funding a lot of these programs. So for them, it's now they have to interact with child welfare, which before they didn't. And it's in a huge lift to kind of change that relationship model. And also Medicaid operates very differently than child welfare, just in basic definitions. So to them, what is a QRTP, which is that Qualified Residential Treatment Program, would be classified for them as a institute of mental disease, which cannot get Medicaid funding. So we're seeing policies butt up against each other that are working against each other right now for Medicaid. And that's a huge issue Kentucky is spearheading. And it's most likely going to require some sort of regulatory fix. But right now it's very hard for Medicaid and child welfare to work together because of existing regulations that make it really hard. The standard of evidence and the rate that the clearinghouse is operated. So that I just want to quickly touch on is it's moving very slowly, and there's not enough programs to fit the population. And there's several transition bills active in Congress right now, 3. So it is going to be interesting to see what happens in the future, but that's sort of the state of Family First right now. And I know we're butting against time, so I'll hand it over back to Adam.
That was perfect. Thank you. Fascinating and genuinely important. I hope we do more work around this and learn how we all can contribute to making this successful. Does anybody, before we start to wrap this up and finish the last couple parts of this this call, anybody have a comment or a question? I'm going to leave that wide open rather than asking a pointed question, just because we're short on time. But we do have time for one or two questions or comments if you have them.
So Adam, this is Dave Walsh. I have one question, and that is, when you look at the overall data that is maintained by systems like this, how many systems are there out there? Is there one per state? Is there one per county? Is there more than that, that actually contain the data that needs to be manipulated and managed to be effective?
I'm sorry, my audio cut out at the end of that. Can you repeat?
Sure. I'm just trying to get a sense for how many systems there are nationwide that contain the data that needs to be exchanged here. Is there one per county, one per state, more than that?
Yeah, so that's going to depend on how the state is set up in their delivery of services. Some states are county driven, which would have a separate county system. A lot of states operate just at the state level, so there would be one integrated system, but that has a lot to do with the different, how it's set up, but then also different states have different data idea. I'm trying to think of the right way to, some states are very innovative with what they do with their data and how they're sharing, like in Allegheny County. So it depends if they're running pilot programs. So generally, I would say there's probably a couple places where these data are housed per state.
Got you. Thank you.
And the answer is a boatload.
A boatload. Thank you, Ed.
I mean, the complexity of this thing can't be exaggerated. One last question, if anyone has it. We'll start to wrap up. Okay.
If nobody else has one, Adam, I'd like to add one additional question to that, and that is, has anybody given much thought to identifying the data that would be most effective to be exchanged and improve these programs?
I'll jump in if you. I think the clear answer, Meg, is no. That this is really, they've barely figured out how who can use what funds and when, and I don't think they've gotten there yet. Meg, what do you think?
No, yeah, I was taking a second to scan my brain, but no, this is a conversation that I've been having with our vendor community a little bit too. Is getting into what granular data our child welfare administrator is going to be looking for now. What are we looking for? What's important? And those conversations haven't happened yet, because the big conversations of who is funding this and you know, whose responsibility to maintain the program is this? And so those, I think we're really going to see once we get an implementation bill passed and states feel a little bit more comfortable moving forward, we'll see those conversations start to happen. And I'm really interested to see what data is going to be important. You know, is it stable housing? Is it addiction? So it's a great question. Unfortunately, I do not have a good answer for you other than we shall see.
Stay tuned here.
I think there is no answer yet, no good answer yet. So we're going to wrap up. Dave, we're going to skip the only thing I want to say about Project Unify, which is our proof of concept project that this group is working on, is that there's child welfare right there. And it is certainly one of the domains, one of the areas that we think that this project is applicable to. And now knowing that they haven't gotten very far in figuring out what data, much less how to transfer it, I think this becomes all the more important that we do work like this. And so again, for those of you, especially new folks, but anybody on the call, we really invite you to participate in the shaping of this project, because you can help inform us in ways that make it genuinely useful at some point as it proceeds. So, and Dave, with apologies, I think respectful of people's time, we're going to keep going, and you will give us a better fill on our next meeting, okay?
Next time.
Next time for sure. So our next time, and you will be part of that one, Dave. This was time very well spent, by the way. Please, I invite everyone to come back to hear more about the project, but we came here for a purpose, and that was a great job. So thank you a lot for the presentation. We're going to skip next week, as I said. The following week, we're going to look at the Da Vinci project. Many of you know what that is. And we will have the program manager for that project, Jocelyn Keegan, as our primary speaker. That should be really, really strong and informative for this technical group. And let me just say, and then we will take some breaks in December. We haven't figured out all the presentations, but we will not invite anybody to come listen to us instead of spending time with their families over Christmas or Hanukkah, okay? But we do ask you to keep an eye on the website, sign up for this group, sign up to be part of NIC. We very much want participation from as many different areas as we can garner. That's the whole idea here. And we thank you enormously for the time you've given us today. I wish everyone, on behalf of everybody at Stewart's and Nick, I wish you all a very, very happy and delicious holiday. And thank you.
Thank you, Adam.
Thank you.
Thank you.
Take care, all.
Thank you.
Bye-bye.
Bye.
Bye-bye.